Ladies and gentlemen, boys and girls, welcome to the March Editor's Insight podcast episode of the Indian Journal of Anesthesia. This episode, we have something very interesting. We have three eminent academicians joining us to discuss about a few interesting subjects that were in the articles which were published in the March episode of Indian Journal of Anesthesia. I am Murli, your host for this episode. And joining me first is Dr. Ramkumar Venkateswaran, the founder editor of the journal Airway, which is the official journal of the All India Difficult Airway Association. Ramkumar sir is an eminent academician who was heading the Department of Anesthesia at Kasturba Medical College, Manipal. Welcome to the podcast, sir.
Thank you, Murli, for that introduction. And I must say that this is a great initiative from the Indian Society of Anesthesiologists. And we can always expect something new to happen when Dr. Rakesh takes on the mantle of a new role in any society. And I'm not surprised that this is a brainchild of the Indian Society of Anesthesiologists. And I listened to some of the earlier podcasts and I was really impressed that this is yet another way of connecting with our anesthesiologists of India, one of the academic platforms through which we can connect. So thank you very much for inviting me onto this episode.
Thank you very much, sir. It's an honor to have you as a speaker today in our podcast. And looking at the March episode, I'm sure you would have come across an interesting article which was about preventing reintubation in the intensive care unit and in patients with high risk of extubation failure. Now, this was something which actually intrigued me because extubation failure is something which we do not come across that commonly when we read for exams, vivas, or academic challenges. So my question to you would be mainly regarding extubation, and we'll discuss a little bit more about extubation and your insights about extubation. So in your opinion, what are the common challenges that the anesthesiologists face during an extubation process?
Right, Murli. As you mentioned, the article that is featured in the March issue is centered around extubation in the intensive care unit, and also looks at some of the methods of supporting a patient that is just being taken off ventilatory support. But I think we could probably keep our discussion a little more, broad-based, so that we can talk about common challenges that anesthesiologists and intensivists face at the time of extubation. And talking about anesthesia, and I think most of the people on this listening to the podcast would be anesthesiologists, maybe especially interested in intensive care. But the first thing that we need to convince ourselves when we reach the point of extubation is how well reversed the patient is at the time of extubation. Majority of patients who are intubated are paralyzed. And one of the problems that the anesthesiologist would face is to identify how well the residual neuromuscular blockade has been antagonized. Now, in most institutions, we stick to clinical parameters. We ask the patient to open the eyes, put out the tongue, grip the hand. These are all clinical parameters, and we know that these are not very accurate. And some of us who have the luxury of having a peripheral nerve stimulator can also look at both qualitative and quantitative evaluation of the recovery from neuromuscular blockade. I emphasize this point because a lot of respiratory complications occur following extubation, not necessarily on table, but it may happen in the post-operative period, and this needs to be kept in mind. And majority of these are because of inadequate antagonism of residual neuromuscular blockade. So that's one of the first things that we need to do. And I think if we are really academically thinking, all of us should use a peripheral nerve stimulator and ensure that our patients are adequately antagonized from the neuromuscular blockade before they are shifted to the post-operative ward. The timing of extubation, of course, there are two extremes of it. Some of us, most of us extubate our patients awake, but we do know that there are some situations where a deep extubation has to be done. And I would just say in passing that most of us are comfortable doing an awake intubation, but the deep, an awake extubation, but the majority of us would think twice before we extubate a patient in the deep plane of anesthesia, and that's only required in a few small category of patients. So this is another thing that we need to keep in mind. Often there's also a production pressure from the administration, maybe from the surgical side also, where the turnaround time of patients has to be minimized. And this often leads to sometimes, doubt in the mind of the anesthesiologist whether to extubate, even if you feel the patient is not going to be adequately breathing in the post-operative period. And some of the younger people also, younger anesthesiologists may also think that if I do not extubate this patient, I may be considered as an incompetent anesthesiologist. And therefore, they might extubate a patient when they are not really ready for it. So these are some of the common challenges that I think anesthesiologists at various levels of practice would face at the time of extubation.
Thanks, sir. That was really very well highlighted. And as you said, the production pressure is something that many people face, especially when they have a busy practice and wanting to extubate and move on to the next case. So that is something that has to be kept in mind. The other thing which we always learn from the time we are postgraduates is that intubation can be elective or can be in an emergency situation, but extubation is always elective. And when we listen to this many times, we don't realize the importance of it. But what do you think are the best practices for preparing when somebody has had a difficult intubation and it is considered a difficult extubation at the end? So what would you think are the best practices? Because this is, again, purely elective. Extubation is considered as a purely elective intervention.
I think, yeah, that's a very important thing that we need to remember. And having said that, if the first intubation has been difficult, it is only natural that we would think that the second intubation, if at all it is required, following an extubation at the end of the procedure, is likely to be maybe as difficult, if not more. And therefore, we need to first review what was the difficulty at the time of the first intubation. Was there any difficulty with face mask ventilation? Did we have to use airway adjuncts to open the airway? What was the best laryngeal view that we got at the time of the first intubation? And did we use any special airway techniques to secure the airway? All of this will have an impact upon our extubation. And ideally, the same person who has done the same team that has done the intubation is also available at the time of extubation. Then they know what kind of a problem to anticipate, and they would keep the same equipment ready. We also need to identify any anatomical factors that might have worsened with surgery. Like, for example, a patient with an oral cancer might be already a difficult intubation, but at the end of the surgical procedure, we may find that the thing has got more complicated. The intubation may have become more complicated because of the surgery itself, maybe a hemimandibulectomy. So surgical reasons for worsening of airway difficulty should also be kept in mind. And of course, the more experienced we are, the more problems we have faced at extubation. And therefore, we all have a checklist. And the checklist keeps growing longer and longer, the longer we have practiced anesthesia. So all these various instances that come to our mind where we have had a problem with extubation will definitely go through our mind before we extubate a patient. I also would like to say that, when the first intubation had been difficult, it is better to have a difficult airway cart ready with appropriate equipment, because you know what's the nature of difficulty you had faced, and also ensure that adequate help is available. Preferably somebody at least at your level of experience, or maybe even more senior, because the thing could be more complicated at the end of the operative procedure. And if you think a surgical access may be required, it's a good idea to discuss with the surgeon and make the surgeon sure that the surgeon is available at the time of extubation, so that should the need arise, we can go for a surgical access to the airway. So I think this would be some of the practices that should be kept in mind when we are planning extubation of a patient who was previously a difficult intubation.
Yes, sir, I agree. And what do you think are the differences when it comes to, say, somebody extubating an adult patient and a pediatric patient? Because now with the school holidays coming up, I'm sure many people listening to this podcast will be anesthetizing more children, because this is when we see a rush of pediatric cases coming in. So do you think it will actually have any difference in the way we should plan for an extubation in a pediatric airway?
Well, the thing is, see, all anesthesiologists cannot deal with a pediatric patient. And all of us cannot consider ourselves specialists in the pediatric management. I would say anesthetic management, leave alone airway management itself. Having said that, any critical incident that would happen in an adult vis-a-vis a child, in a child, it actually pushes out more adrenaline in the person who's managing the case. So pediatric emergencies are always a little more scary than they would happen in the adult. And therefore, we should ideally plan these patients. If you're not a trained pediatric anesthesiologist, if you're an occasional pediatric anesthesiologist, it's always good to have a pediatric anesthesiologist available, at least on call, at the time of extubation. And you should definitely discuss the entire plan of action. Just like you have an option A, B, and C for intubation, you also need to have several options available at the time of extubation so that if one fails, you're always ready to go on to the next. Remember that though we may say that the difficult airway cart should be ready, very often difficult airway carts are not equipped with all pediatric-sized equipment. And therefore, I think when we deal with a difficult pediatric extubation, one has to physically check and make sure that appropriate sized airway equipment are available to deal with a re-intubation if at all it becomes necessary. Remember also that children desaturate much faster. So our, it should be the need to call for help, the time to call for help, the time to escalate our intervention should be much faster in a child because they desaturate much faster. I think that's how I would approach a pediatric airway, a difficult pediatric airway, in contrast to a difficult adult airway.
And what about people with patients with pre-existing respiratory conditions? So we have patients with COPD, various lung conditions coming in, and also ILD, are all difficult airways to start with. So is there anything there that as a strategy or a mantra that you have?
Well, these I would classify them as a physiologically difficult airway because, of course, in addition, they could also have an anatomically difficult airway. But just the fact that a person has COPD, asthma, or a hyperreactive airway does not necessarily make the airway difficult to intubate or extubate. However, having said that, we need to call upon certain measures to make the extubation smooth because these patients are likely to have a hyperreactive airway. And that's where we need to make use of pharmacological agents, such as maybe the various methods that are described, maybe intravenous lignocaine in the alkalinized lignocaine in the cuff at the time of intubation itself, and use of a bronchodilator puffs just prior to extubation. All these may help. And these are the situations where maybe if you're expert enough, you can also consider an awake intubation so that the airway reflexes are depressed at the time of extubation. So I think the basic idea in all these situations that you've enumerated, Murli, is to try and avoid the reflex response of the airway to an extubation. And, of course, there are other categories of patients also who have cardiovascular problems where the hemodynamic responses also need to be considered. So these are physiologically difficult airways. And of course, on top of that, you have an anatomical difficulty also that compounds the problems.
So now many of our listeners might be practicing in the periphery or they might be doing private practice wherein they might have to kind of cover more than few hospitals. So if I were to ask you, what 3 or 4 devices that you would like to buy and keep with you when you are on the move, which will help you in a difficult extubation?
Oh, that's a very nice question because fortunately, I've always been working in an institution, but I also gave a lecture once in Bombay, which touched upon this topic. And I think the introduction of the supraglottic airway device is a boon to every anesthesiologist because it can act as a device to secure an airway temporarily or maybe even to conduct the entire procedure if you're not able to intubate the patient, and can also act as a method to step down upon from an intubated patient in the event of a possible difficult extubation. So I think the supraglottic airway device, a series, the entire all the sizes of supraglottic airway devices would be a good thing for people to have around, even in the institutions or setup, which is not as well equipped as a teaching institution. The other thing I think, which is relatively inexpensive, is an airway exchange catheter, especially one that is what's called a hollow airway exchange catheter. One of the prototypes is the Cook's airway exchange catheter, which will not only help you as a conduit to re-intubate a patient who has been difficult to intubate in the first instance. But it may also, in the hands of experts, you may be able to give very low flows, maybe 1 to 2 liters of gas oxygen flow into these airway exchange catheters to even keep up oxygenation if at all the oxygen levels start dropping. So I think the supraglottic airway device is definitely one. The airway exchange catheter is definitely something that's worthwhile to have in our armamentarium, especially if you're in a situation where we do not have a lot of fancy equipment.
You mentioned a lot of very important points here. And all of us as anesthetists have faced extubation issues during our career. And as you said, the more the experience the anesthetist, the more he would have faced and the more the wisdom. So in your experience, can you share any memorable case or cases which actually impacted you when it came to extubation failure and how you learned from it?
Yeah, these were early days in my career. I was a senior resident in the institution where I trained. And those days, we used to do cesarean deliveries more often under general anesthesia than under a central neuraxial blockade. I would say 8 out of 10 patients coming for a cesarean delivery were done under general anesthetic. And I still remember, in fact, even now, once in a way, I get up in a sweat at night thinking about this patient. I lost a patient of preeclampsia, who, of course, we did under general anesthetic. And at the end of the anesthetic, I extubated the patient because she was coughing on the tube. However, we all know that patients of preeclampsia, they do have an excessive sensitivity of their upper airway to sedative medications. The obstetrician also had used a lot of sedation in the labor ward. On top of that, we had given a general anesthetic. So all put together, maybe her airway reflexes were not really recovered to that level. So I extubated the patient very foolishly now thinking back, because she was training on the tube. And I sat with this patient for about 45 minutes and then went back to the duty room. And an hour later, I get a call saying that she has regurgitated and aspirated. And unfortunately, she succumbed to that aspiration. So I think, airway reflexes also need to be kept in mind when we talk about, really need to have a protected airway when we think of readiness for extubation. Not just, the need for reintubation, but also are they ready to protect their airways once we have extubated, depending upon what sedative medications you have used in the during the anesthetic period. So this is one case that now stands very high up on my list, and I really feel that obstetric deaths should be avoided at all costs, and this is something that weighs very heavily on my conscience, and every now and then I think about this case when we talk about complications in anesthesia.
So thanks for sharing such a, I would say, a personal experience that you had, which still lingers. I'm sure all of us have such patients who keep coming back to us, and the more junior we were, the more errors or mistakes that we have done, which comes back to us. On the same note, what tips would you give young anesthesiologists who are beginning their careers on this process of extubation? Any, like a rapid fire, can you just give us a few points as to what would you think are the most important points there?
I think the first thing would be, that we should never burn our bridges before we cross it. So we have an airway in place, and as you emphasized right in the beginning, Murli, extubation is always elective, and there is no hurry to remove a tube for any other reason until and unless we feel that the patient can maintain their airway on their own. So I think that is the first thing that we need to keep in mind. Make sure that we extubate the patient only when we are sure that the patient post-extubation will be able to maintain their airway well. Now, having said that, I think for the youngsters, I would say that patients who have undergone oropharyngeal surgery, upper airway surgeries, where there's likely to be blood in the oral cavity, maybe debris in the oral cavity, maybe tonsillectomy, cleft lip and palate. These are the kind of cases that lead to a problem with blood and debris in the upper airway. And these are best extubated in the lateral position, so that not only do the secretions flow forward, but the tongue also falls forward, and you can also, open up the jaw and make sure that the airway is patent. We also need to keep all airway adjuncts ready of appropriate sizes. And if you suspect that there may be a problem at extubation, it's always good to have a couple of endotracheal tubes, ideally smaller than the one that you've used, zero point 0.5 to 1 millimeter internal diameter smaller than what you've used. In case there's been a prolonged surgery or you had repeated attempts at intubation, you can expect some laryngeal edema at the end of the procedure. And therefore, we can keep smaller size endotracheal tubes ready. Never miss an opportunity to oxygenate. Oxygenate prior to extubation, oxygenate soon after extubation, oxygenate on the way from the OT to the post-operative recovery area. And nowadays, pulse oximeters are available for a dozen for a dime. Like they're very, very inexpensive. And you should always have at least a pulse oximeter connected to your patient during transport so that you can not only have an indirect idea about what is the heart rate of the patient, is the patient breathing, is there a good saturation. So I think that would be one way of also making sure that you ward your patient in the recovery area in as good a condition as is possible as they left the operating room. For the youngsters, since you specially said, advice for the youngsters, don't be too bold. If you had a problem at intubation, no matter who your senior is, ensure that they are called back at the time of extubation. Do not attempt extubation on your own. It's always a good idea to have your senior available, and they will have the best ideas to tackle any situation, and you can learn from those situations. So have the senior available, the same senior preferably who was there at the time of intubation, because then he or she will also know what kind of problems they faced at the time of intubation. And they'll be available to appropriately deal with any difficult situation at that point. I also notice when I speak to my colleagues that in some institutions, for what they consider good man management strategies, sometime late in the evening, patients surgeries that are going on beyond a particular time are taken over by what they call a duty team or a late evening team. I think this is not a good idea. It may be a good man management strategy, but any patient who's having a complicated airway, it is best that the same team that starts the procedure also ends the procedure. And extubation is best done by the person who knows what the problems were at the time of intubation. So I think that is another thing that, because juniors again may hesitate, since you said it's advice for juniors, they may hesitate to call the senior for help. But I think in the long run, you will thank yourself when you land up in some kind of trouble. So make sure that your senior is available at the time of extubation, when your previous intubation has been difficult.
Thank you, sir. Thanks. Those are really key points there. Now, if there is one thing that you're excited about when it comes to the field of extubation, this is my last question. So what would that be?
Well, lots of equipment come in and they are tried for a few years and then they find their exit. So I think, as I mentioned earlier, supraglottic airways will have a very important place in all difficult airway cuts, because they definitely give the anesthesiologists that extra string to their bow to maintain oxygenation at any point of time, be it at the time of induction or extubation. So I think the supraglottic airways, already we have got so many new gadgets coming in among the supraglottic airways that have taken care of the problems of the previous generation supraglottic airways. So that's one thing I think that's still exciting to me, though it's not a new technique or a new device. The other thing, of course, is I also have seen several articles where different types of airway exchange catheters have come in, have been used for a few years, and have gone away. But I think any type of airway exchange catheter is still will be a very good device to have around, when we are dealing with a difficult extubation. The other thing that's now come up, come up into practice in many institutions in India also, is what's called the Thrive. That is the transnasal humidified rapid insufflation ventilatory exchange device. Now, this is something that was very much part of the emergency room, which was used in the ICUs also, as is described in this article in the March issue of the Indian Journal of Anaesthesia. So the high flow nasal oxygen, the Thrive device were all available in the ERs, emergency rooms, and the ICUs. But now they have slowly started coming into the operating rooms. And I think this is a device that takes a lot of stress out of the anesthesiologist's practice. Because here is one method of ensuring oxygenation and maybe even carbon dioxide elimination to some extent in a patient who has a potentially difficult airway. And the other thing is, I heard recently I'd gone for a conference about a month ago, talking to some equipment manufacturers, and they were saying that very soon, Thrive is going to be introduced as part of your anesthesia workstation. So no, when I started my training, the anesthesia machine just consisted of a pneumatic device to give a specific flow of gases. But then the workstation became more and more complicated. We added monitoring devices, we added ventilators. And now I think I look forward to the time when the Thrive or a Thrive kind of device is going to be added onto the anesthesia machine, which will definitely take care of oxygenation problems, both at the time of induction of anesthesia and at the time of extubation. So this is, I think, one of the new things that I hope will soon be incorporated into our practice.
Thank you, sir. Thanks for all the wonderful insights. And it's been like a masterclass on extubation. And as it is with the circle of life, I am very fortunate that I've been able to talk to you on this podcast. And I was examined by you as an examiner 22 years ago. And I cannot forget that day. So thank you very much for joining us and sharing your insights. Thank you very much, sir.
Once again, I thank all the office bearers of the Indian Society of Anesthesiologists, particularly Rakesh Garg, who is probably the mastermind behind this, and Murli for conducting not only this interview, but I've listened to some of the other podcasts. You have a knack of getting answers out of people. Thank you so much for having me on this.
Thank you very much, sir. Thank you. Thank you. The next guest on our episode this evening is Dr. Atul Kulkarni, who is the editor-in-chief of the Indian Journal of Critical Care Medicine, the official journal of the Indian Society of Critical Care Medicine. Welcome to the show, sir.
Thanks, Murli. And Rakesh, thanks as well. Great to be here.
Thank you very much, sir. Now, in the March issue of Indian Journal of Anesthesia, there was an article which was looking at two scoring systems and the prediction of mortality in patients undergoing laparotomy. So we thought you would be the best person to discuss the topic of scoring systems and understand more about what is happening in this field. So let's start with what is a scoring system. Now, why scoring systems are important?
So scoring systems do two main important things. They help us in judging the severity of illness of a patient and individual patients. However, you can't really use the scoring system for predicting any type of outcomes for individual patients. So you can predict the outcomes in a group of patients, but not really in an individual patient. You can make a generalized comment, sir, if for example, the sequential organ failure assessment score of, say, so the normal score ranges from 0 to 24. So 6 organ systems are given points from 0 to 4. And depending on what the score is, you can say that this patient is worsening, means more organs are failing. And you can say a general prediction like whether if 3 organ systems are failing, then maybe the outcome is likely to be, or so many patients, or this percentage of patients are likely to die. Against someone whose SOFA score, it's called SOFA score, which is getting better, that tells you that the patient is getting better. And many studies actually look at the sequential scoring of the SOFA score, say for day 0 to day 3, and they will then look at the average score on day 3 and day 0 and say that the patient is getting better or worse. So if you do an intervention and the SOFA score gets better in that group of patients where the intervention is being done, then it will help tell you that this intervention is probably effective, but it's a soft endpoint. The other thing the scoring systems do in the intensive care unit is that you look at the first day score. So most scoring systems will look at the score on the after the first 24 hours of admissions. So there are scoring systems which look at, say, for example, mortality prediction model of 0, which looks at the score at that time of admission, or MPM 24 or things like that. But APACHE 2, for example, the acute physiology and chronic health evaluation score, takes into consideration the physiological score or the severity of illness at the time, plus the comorbidities of that patient. And for a group of patients, you can actually judge how your ICU is doing. And for example, you can compare my ICU with your ICU in Apollo and say that the standardized mortality ratio of two different hospital ICUs may be different. And that tells you about the performance of the ICU in comparison to the other ICU. Similarly, you can put in something in place, some intervention in place, and see the effect of that intervention in your own unit after a period of 3 months or 3 years or 6 years, and say that because of that intervention, our standard of management in our ICU or quality of management has improved. So you can judge the improvement or degradation in the quality of services you offer. So there are multiple uses of severity of illness scoring systems, but they are generally not supposed to be used for predicting outcomes in an individual patient.
So what are the common scoring systems that you would use, sir? I mean to say, in your ICU or in at least, in the network of ICUs that you work in?
So the commonest scoring system that is still being used is APACHE 2. That is because the prediction model or the equations are freely available. APACHE 3 is available. APACHE 4, that is the latest scoring system, just tells you the free part, just gives you the prediction of length of ICU stay, but does not give you the mortality. So you cannot calculate the predicted mortality, and therefore you cannot calculate the standardized mortality ratio unless you have paid for it. So
Okay.
it's a paid kind of system. The other common system in use is what is called as a simplified physiological score. So SAPS 1, SAPS 2, and currently we are on SAPS 3. SAPS 3 is freely available. So simplified acute physiological score tells you the same things, but it mainly takes into account the physiological score. The SAPS 3 model actually takes into account also the setup of your ICU. So that is the last edition of the SAPS score that was designed some time back. And many ICUs from India had actually participated in development of SAPS 3.
And what about the scoring systems when we take it out of ICU and put it into perioperative context? Are there any important scoring systems that you would like to highlight which can be used by an anesthetist in the perioperative period when it comes to a sick patient?
Yes, the commonest system that is used is the POSUM score. Okay, so it was developed in Portsmouth in UK, and it's the physiological and operative scoring system to predict post-operative outcomes. So this study in IJA that is published in the March issue is very interesting, because I am not sure from the methodology how the APACHE 2 was scored. So normally, I understand that it was scored preoperatively to look at the post-operative outcome in that group of patients. And they also use the American College of Surgeons score, Quality Improvement Project score in that group, and they compared that. And because generally for APACHE 2, you need to take a 24-hour period into account. And then I'm not very clear from the methods whether they have taken the 24 hours. So the common perioperative scores that are used are, apart from the Lee's revised cardiac index, etc., which is not really a severity of illness scoring system. POSUM is a classic severity of illness scoring system which has been developed specifically for using in the perioperative period.
And what about having these scoring systems to grade the risk? Now, example, now somebody is posted for hip surgery tomorrow who's got multiple comorbidities. Do you think an anesthetist can use any of these scoring systems to either communicate the level of risk to the surgeon or to the patient
Yes.
relatives?
So many of these scoring systems, for example, POSUM, the score is freely available. So the calculator is freely available online. And if you have a patient who is very sick, then it actually gives you a percentage of score in morbidity as well as mortality, a prediction. So when you are talking to the relative, you can tell the family and the patient that, look, your patient has 1, 2, 3 problems or comorbidities, and though there is the operative score is not largely into account, the physiological score and the comorbidities and the operative part, three combined together will give you a rough idea um about the likely outcome of the patient in terms of possible morbidities and mortalities. The 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 problem with this is that POSUM has been used for multiple surgeries for predicting outcome. For example, colorectal surgeries and many more. Uh, there are scoring systems which you can use in the uh, in any surgery. For example, such as surgical Apgar score. Now, surgical Apgar score is something which just tells you about the hemodynamic instability. It just takes into account 3 points, and you can score it at any time during the surgery and predict what the likely outcome is. But again, the problem with using the scoring systems developed in some other place, for example, say developed in West, for example, POSUM was developed in UK. Applying it as in toto to our circumstances may not be a correct idea. For example, there was a very nice study by Dr. Parikh, Dr. Parikh and Dr. Karnad from KEM Hospital in Bombay, which was published in early 90s, I think, in critical care medicine. And they looked at the standardized mortality ratio uh, of their patients, their ICU patients, uh, as compared to the score of unity, that is 1. And their SMR was 1.4, I think. The problem comes because when the scoring system is developed in a particular population, for example, Americans don't get malaria and Americans don't get dengue. So this population is not represented in that development cohort, what is called as a development cohort. So it is unlikely to be able to predict a population in which these diseases are prevalent. For example, organophosphorus poisoning or snake envenomation. So you cannot employ these systems in toto in a new population unless your populations are basically similar. So what you need to do for using such systems is to validate these systems in our circumstances or in our ICUs or in our patients undergoing surgeries in our hospitals with the resources that we have.
Thank you, sir. In fact, you have given a nice idea for many listeners here for idea for publication. So, validation of
That's great.
scores which have been done in the Western world definitely need validation here. And another question, in fact, there are two questions in one, the next one. Why do you think scoring systems are not widely adopted across? I mean to say, I'm talking about the entire world and more so in India when it comes to either perioperative period or the intensive care. And the other part of the question is, how do we encourage people to start using scoring systems? And what are the advantages? Now, if you can just take both the questions and answer this, please.
Okay. So the reason for the scoring system not being widely used in most of the world or being used only in academic centers
Yes.
is mostly to staffing. In the sense that you are always, Indian hospitals are mostly short staffed and we hardly find time to actually document the procedures that we do and the anesthetics that we do properly in the case records. So meticulous record keeping is extremely important to develop or calculate an accurate score, because if your score calculation is not accurate, it is not going to give you correct result. The advantage, if you put in that effort, particularly in ICU and in the operating rooms, which are high acuity areas with high chances of morbidity as well as mortality, the advantage is that you have a complete record of patients' comorbidities, the physiologies, and the problems faced by the patient in the perioperative period. And that will in turn help if, God forbid, there are medical legal problems in future. Because it automatically ensures that your records are meticulous. Because you are trying to score for the patient and look at the prediction of the outcome.
And how can we integrate these scoring systems now that most of the hospitals are moving towards electronic medical records? Do you think?
Excellent.
Do you think if
Excellent.
if we move towards EMRs, then incorporating it at the start would be a better idea rather than building it later?
Yes, absolutely. You're absolutely right. And in fact, it should be easier in the operating rooms, because you have all the variables available. You are, because they can be directly fetched from your monitors and the ventilator that you are going to use. So you will get the concentration of oxygen, nitrous oxide, the inhalation agent, the opioids you will have to enter, but that you enter anyway. So that will all be fetched from there. The vitals are going to be fetched. The settings as well as the monitoring of the ventilation is going to be fetched directly. Actually, using these systems, scoring systems from the ICU records is slightly more difficult, in the sense that if you take the example of the most common used system, that is APACHE tool, and people try to fetch the data from the monitors in the ICU for scoring the APACHE 2 on the first 24 hours. The problem in the ICU is that if the patient moves or patient is shifted for some procedure, the monitor records the blood pressure and the heart rate, etc., as 0. And that is taken as the worst value of that patient. This problem should not arise when you use EHR in the perioperative period when the patient is in the OT. So when you disconnect the patient, it says disconnection and not heart rate at 0 and the blood pressure at 0. So hopefully many hospitals are adopting these EHRs, and we should be able to use scoring systems in, at least in the perioperative period, much more frequently and more accurately in future than what we are currently doing.
Thank you, sir. Thanks for all the insights that you have given regarding the scoring systems. I'm sure people are only worried about one score nowadays, that is IPL, their favorite team score.
Yeah,
but today you have highlighted a different scoring system and the importance of it for patient outcomes. So thank you once again for joining, and congratulations for the entire editorial board of the Indian Journal of Critical Care Medicine for the impact factor of 2, which has been announced recently. So congratulations to the entire team, sir.
Thank you very much, Murli, and thanks, Rakesh, and thank you very much for having me here.
Sure. Thank you very much. Thank you, sir. The next guest we have this evening is Dr. Diwatia. Dr. Diwatia has been the editor of the Airway Journal, the editor-in-chief of the Indian Journal of Anaesthesia, the past president of the Indian Society of Critical Care Medicine, the All India Difficult Airway Association, and presently he holds the post of the president of Indian Society of Anesthesiologists. Welcome to the show, sir.
Yeah, good evening, Murli, and good evening, Rakesh, and thank you very much for having me here. I guess I'm not here in any capacity as the president of any association, but hopefully as someone who can hopefully contribute to some more on the discussion today.
Sir, you're here as an academician to share your insights. And the introduction was mainly to highlight the various positions that you held in the past and presently hold.
Okay, so thank you, Murli. I'll be very happy to engage in any discussion with you.
In the March issue of Indian Journal of Anesthesia, there was an interesting article, which was actually a systematic review looking at surgical scrubs outside OT. Now, it actually was a very interesting article because It highlighted the importance of perioperative infections and surgical site infections and the role of anesthetists. So I just want to ask you on the same topic a few questions as to what do you think are the common risk factors here for surgical site infections and how can they be mitigated?
Yeah, so Murli, that was a very, very interesting article, and it was very relevant, I think, especially in our hospital, because we wear scrubs in the OT and we wear the same scrubs outside, and we move around the hospital in the scrubs. And this article did not find any increased incidence of colonization with bacteria or pathogenic bacteria in the review that they did. So as far as the risk factors for infection, surgical site infection in surgical patients, I think the moment you breach the skin barrier or a mucosal barrier, you're going to expose the patient to a risk of infection. That's a given. But I guess age would be a risk factor. Immunosuppression would be a risk factor. The type of surgery would be a risk factor. So clean contaminated versus contaminated operation would be a risk factor. Prior antibiotic therapy would also be important. So one of the very important risk factors is the practices that we, especially simple things like hand washing, simple things like the type of scrub that we use to clean or prep the patient, the precautions that we take to put our lines, our central lines, or arterial lines, or even intravenous lines in, how we do our lumbar punctures or our epidurals. So basically the aseptic precautions, the level of aseptic precautions that we use in our day-to-day practice, the way we drop drugs. So all those things have been shown to contribute to infections.
And what about the role of maintaining normothermia and optimal glucose control? Because anesthetists again play a very key role here in this domain.
So I think that's a very important aspect that you've brought out. So I think there are 3 or 4 things that we do in the intraoperative period that can actually help reduce the incidence of surgical site infections. And you mentioned 2 of them straight up, so one is maintenance of normothermia. And there have been a number of randomized controlled trials which have shown that if you maintain normothermia, which is a temperature of 36.5, it is better than any prophylactic antibiotic. It reduces the incidence of surgical site infections by almost 1/3. So, it's by 1/3, not to 1/3. So almost 3 times difference in the risk of surgical site infections when normothermia is maintained. Similarly with glycemic control, and you see the cardiac surgeons like very tight glycemic control, because it's been very well shown that that tight glycemic control, which means a blood glucose of 110 to 140, reduces the incidence of wound infections and cardiac surgery and orthopedic surgery. It means bone infections and sternal infections significantly. One of the downsides of maintaining such tight glycemic control is you need very tight, very rigid glucose monitoring. Otherwise, there's a risk of hypoglycemia. And hypoglycemia in an unconscious anesthetized patient can be disastrous because there are no sort of premonitory symptoms or signs that you can see. And therefore, one is, suppose you have tight continuous monitoring of blood glucose or very frequent monitoring of blood glucose, but many would say that a glucose target of 140 or 150 to 180 is also a very reasonable target, and that also significantly reduces infections. So in the post-operative period, also maintaining glycemic control reduces the incidence of sepsis, reduces the incidence of bloodstream infections, wound infections, and overall morbidity. So I think glycemic control is extremely important. Tight glycemic control to blood sugar of 110 to 140 exposes the patient to risk of hypoglycemia. But I think even a moderate glucose control, which means a blood sugar of about 150 to 180, also helps with the patient in reducing to reduce the risk of infection with a much lower risk of hypoglycemia. So these 2 interventions are extremely important. The third important way in which the anesthetist can contribute is, the pre-op antibiotic therapy as part of the surgical safety checklist. So in the surgical safety checklist, in your timeout, you need to make sure that you've given the antibiotic. And in fact, we should give the prophylactic antibiotic 1 dose with the induction of anesthesia, so that by the time the patient is prepped and draped and ready to go, you've got a significant amount of time has elapsed and the patient, they've got a nice high antibiotic level at the time of skin incision. So I think that's the other very important sort of thing that can help reduce the surgical site infections.
Now, I'm sure, so the WHO checklist has made a huge difference in the antibiotic being given and also the cross-checking that happens whether the antibiotic has been given before incision. But definitely there are many challenges and barriers to implementing the best practices. So in your view, what do you think are the barriers? Now, we are talking about a country where there is a huge diverse way of practicing anesthesia from the educational institutions to the periphery. So what are the common barriers and how, as anesthetists, especially those listeners who are listening, how can they kind of improve the safety of practice and improve the incidence of surgical site infections?
I think one of the main things is we don't take our role as anesthesiologists in the prevention of surgical site infection very seriously. We there are very simple things that need to be done. For example, hand washing. So, we need to wash our hands before we touch the patients. We need to wash our hands before we handle and when I say wash, I mean, even a alcohol hand rub is a good hand wash. You need to do it after we do a procedure. You need to take proper barrier precautions, especially when you're putting in central lines. You need to take barrier precautions when you're putting in neuraxial blocks. And I see many people who don't do these things. I mean, it's something which is very important. Simple thing like using the same multi-dose vial for multiple patients, not swabbing the rubber stopcocks, using bivalves multiple times without swabbing the tips. So, injecting, puncturing the IV bag to put in some fluid, to mix some drugs or something. So all these things are potential sources of infection. And these are simple things which we can do to prevent infections. We also need to participate overall in infection control in conjunction with the surgeons and the hospital management and the OT management. We need to ensure OT discipline. We need to ensure a proper hand washing again. And if you ask what the barriers are, I think one is not recognizing that we can do a lot more to prevent infection control or to prevent infection. And also we need to educate, lack of education on many aspects, and many old outdated practices still persist. Many of the new current practices are not in vogue. Giving multiple doses of antibiotics for prolonged periods in trying to prevent surgical infection probably doesn't work. All you need to give one preoperative and maybe one intraoperative if the operation goes on, and at the most one more in the post-op period. But it's not uncommon to see multiple long duration of prophylactic antibiotic therapy. I think we also need to, I'm not sure how many of us take part in auditing our performance as far as infection control or participate in hospital audits for infection and infection control. I guess many people do it in the intensive care unit, but we also need to see what are our practices in the ICU. So you need to audit our practices and see what has happened as far as surgical site infections are concerned. We need to audit what sort of temperatures we are maintaining. We need to audit what sort of glucose we are looking at. A little controversial aspect is high FiO2. So there were some papers which suggested that maintaining a high FiO2 in the perioperative period and immediate post-op reduces infections, but that's very controversial. That's why I'm not going to touch.
What about the anesthetists voicing their opinion? As you said, when surgeons kind of insist on having more than one antibiotic given, and which might be contradictory to the policy of the hospital. So where do you think the anesthetist should kind of stand?
So I think for the intraoperative period, it's quite easy. It's not a big problem because you're going to give one antibiotic just before you induce the patient. And then if it's a prolonged surgery, you're perfectly justified, depending on which antibiotic you're using and the pharmacology, to give another dose intra. The problem actually comes in the postoperative period. So those of us who are handling the postoperative recovery or the postoperative intensive care, they are the ones in trouble because the surgeons say, no, you keep giving antibiotics. And I think the only way to do it is education. But I don't think education is going to solve the problem because all our surgeons know the guidelines. In fact, every surgical guideline I've seen says exactly what we are talking today. But they say that I don't believe in this guideline. They may believe 100 other guidelines, but they don't believe in that guideline. And they say you give it. And all you have to say is that, you do it. I don't think you should be doing it. And there has to be some pressure from management. There has to be some punitive or something more than mere education.
A check from the other end.
If I want to use that word, to some sort of check on giving multiple antibiotics doses in the postoperative period. So there has to be a strong infection control committee. There has to be a strong leadership as far as infection control is concerned. And there has to be uniform implementation across the board in these sort of policies.
Now, finally, last question, sir. We'll come back to the same paper, or the subject of the paper is the scrubs. Now, we are seeing, especially post-COVID, a lot of companies advertising scrubs and people wearing fancy scrubs in various settings. So what do you think is the final message to especially, youngsters out there listening to this podcast as to what they should be doing? Should they be wearing scrubs in the theater going out for a coffee, or they should be changing, or what is your take on this?
So, okay, let me go purely by this paper. They did not find any in the systematic review. Overall, there was no increase in, they did not actually look at surgical site infections. I think only one of the papers mentioned something about a surgical site infection. But otherwise, they looked at colonization or presence of bacteria on the and the assumption is that if the more contaminated your scrubs are or your clothes are, the more likely you're going to transmit it to the patient. And that did not happen, at least as far as this systematic review is concerned, that they did not see. In a way, it appears that you do not be too fussed about whether you move around the hospital and using your surgical scrubs, go have a coffee, come back to the OT, or something like that. So at least there seems to be no harm. But you need to recognize the number of patients are very small, the number of studies are very small. Some of the studies were exposed to a high risk of bias. So it's not a very simple or a straightforward interpretation to this. So those of you who believe that you should change your scrubs, should change your scrubs. Those of who you are like us, who have been moving around in our scrubs, it's a little reassuring to know that it's probably not a big problem. But I think it makes sense that if you're moving out, if you don't want to change your scrubs, at least wear something over your scrubs, like a apron or like another gown or something, and then you move out. And then at least, your scrubs are relatively clean. None of us, nothing, even our scrubs are not sterile scrubs. They are only clean scrubs, right? And, wherever you move, whether you move from one OR to the other, you're going to sort of pick up your own foliage you're going to have all those things happening. So we are not going to be able to prevent bacteria from getting onto that, but pathogenic bacteria, probably not. And so I don't think, so while this is an important aspect of overall discipline, it doesn't appear to make a huge difference to surgical site infection. There are many more important aspects to pay attention to. For example, hand washing, for example, proper barrier precautions for certain procedures, prophylactic antibiotic single doses, those things, scrubbing the skin prep solutions that we use, maintaining normothermia, maintaining glycemic control, having good infection control practices while drawing up our drugs and injecting drugs. Those are probably much more important than the clothes we wear. As long as we are not putting our clothes into the patient, I think it should be okay.
Thank you, sir. Thanks a lot for sparing your precious time, joining us and sharing insights about a very important topic, which I'm sure many listeners will be keen to listen to and pick up points.
Thank you, Dr. Murli. Thank you, Rakesh, Dr. Rakesh, for inviting me to this podcast.
Thank you.
And once again, for this one initiative that you've taken in having podcasts based on some papers in the journal. And I think the number of meta-analysis and systematic reviews that are coming out, I think they're serving a very good purpose and integrating the literature for us. And it's a pleasure to read these articles. Of course, some of them have controversial topics. Some of them have controversial conclusions like this current paper. And I probably fueled the controversy a little bit with some of my answers. But I guess that's how science progresses.
Thank you. So finally, as it is tradition with our editors Insights podcast, we have the editor-in-chief of Indian Journal of Anaesthesia, Professor Rakesh Garg. Welcome to the podcast, Dr. Rakesh.
Thank you, Dr. Murli.
Just continuing the conversation that we had with Dr. Diwatia, do you have any insights regarding the same topic?
I think today's podcast was heavily studied with experienced knowledge and a vast contribution today. So I don't have much to say, but yes, in continuation to what Dr. Diwatia was just mentioning, that when we do a research, it is not always that the outcome is coming into one direction. There will be researches which say that A is better than B. Some research will say A is equivalent to B. And there may be few research will say B is better than A or not. No. So these type of things will happen in research, especially with newer things, newer techniques, where we are not very sure about it. And that's why the IJA is publishing meta-analysis where we have some directionality of a particular technique or a drug or a strategy that direction gives a hint that this is better than others. Whenever these controversies happen, I think we also need to get a food for thought that these are the areas where we need to do more robust research. When there is a controversy, this means nothing is very clear. Maybe because it was a small sample size study, maybe that the technique was not so robust. And when we want to clarify those things, we need a bigger sample, more robust strategy so that we can come with some conclusion. So I think in research, everything comes with strong research methodology with appropriate sample size. And then we can conclude with combination of these studies with meta-analysis to get directionality of using a strategy or a drug or any such thing.
Now, as it is the tradition with this podcast, we would like to know a secret, which you tell always it is an open secret. But the question for you in this show is, what advice would you give to youngsters, early career researchers mainly, who are seeking to publish their work in Indian Journal of Anaesthesia, as to how they should go about? What are the tips from your end as editor-in-chief?
I think somebody was discussing on a social media, on a WhatsApp, on directly personal to me, just a couple of minutes back, and same point was being discussed. I said, my small suggestion for her was try to spend some more time. We cannot do anything and everything in a hurry, in a small moment of time and get a good research and its publication. Probably, I think we need to spend little more time to understand. And research is just not doing a technique and documenting the data and analyzing and reporting it. I think it also requires a good understanding of the already existing literature, how we can use them into our clinical practice, and then making a good research proposals and taking it forward. So probably it will be a combination of your clinical experience, expertise, and then putting them into right research protocols and then using the right strategies will help to get a good publication. And when we say good publication, I mean which will change the clinical, which have some clinical translational value. It actually helps the patient. Sometimes I believe when I see the literature and somebody says that drug A increases the duration of analgesia by 15 minutes or 20 minutes and p-value is significant, I really think myself that is a 15-minute increase in duration of analgesia over 24 hours, is it clinically significant to me? we need to think and ponder on this. And when we think on a broader vision and look for ideas which are actually novel, I think it's one of the initial step for getting a good publication. And that initial thought process comes from your expertise and your experience. So be very thoughtful, be very mindful, be very inquisitive when you're getting your clinical cases done. And I'm sure you will pick up n number of ideas actually when you are clinically practicing it. You will realize that this is the limitation in my clinical practice. This is the limitation in this technique. This is the limitation in this drug. Can I do better for my patients? And then you go back and study the literature. I will not so go back and study the literature. I will also suggest, as our senior persons were also discussing, we need to spend every day some minutes for keeping us updated. And that is what we can pick up new ideas. That is what become better person. And that is what will give you an landmark publication also.
Thank you. That covered a lot of topics in just that one question. And thank you again for joining us and sharing your insights. So look forward to asking you a difficult question in the coming podcast next month. Thank you very much.
Thank you so much. And keep reading IJA, keep submitting good articles to IJA, and let's spread the knowledge to the world for improving our patient care and improving the patient outcome. Thank you so much.
Thank you, Dr. Rakesh. So finally, I would like to thank all the listeners who've been listening to this wonderful episode covering various important topics with eminent academicians who joined us. Whether you have been on your morning walk or your evening commute, thanks again for sharing your time and spending time with us. Stay safe, stay curious, and we will see you in the next month's episode. Bye-bye.